So a very good morning to everyone. We are from group rotation 17. Now we are going to present about traumatic cleft palate repair in a domestic short hair cat. So this is a baby, 3 years old castrated male domestic short hair cat weighing about 4.2 kg. Is 3 out of 5. Vaccination and deworming status are not up to date. And baby tomato is managed fully indoor. So the history of this case is that on 21st of September 2020, baby tomato was suspected to be hit by a car, and the owner presented to a private vet, and upon physical examination, the vet found palate fracture with mild mandibular symphysis separation and epistasis. Suturing of hard palate was done day 3 of hospitalization in the private vet. And in 4th of October 2020, the hard palate fracture was reduced markedly, but presented with bilateral nasal discharge and stertorous breathing. So the cat was okay, yeah. And then on 12th of October 2020, second attempt of hard palate repair was done, but it failed due to high fragility of mucosa of caudal oral cavity. So on 23rd of 2021, the owner noticed reduced appetite and drinking, and there was recurrent flu and as well as sneezing, and the stertorous breathing was persisting, and the opening of caudal oral cavity was still evident at that point. So upon physical examination, TP were within the normal range. Meanwhile, the respiratory rate was not available. And then the animal looked bright, alert, and responsive, pale pink mucous membrane with normal skin tone. And we found left submandibular lymph node enlargement. And we still could hear the stertorous breathing with bilateral serous nasal discharge and cleft at the caudal hard palate. So this is the visual of the cleft at the caudal hard palate. So our problem list, first problem is opening of at hard palate and soft palate. So the diagnosis is cleft palate. The plan is to do surgical repair, cleft palate repair. And then second is bilateral serous discharge, and it was diagnosed as a feline upper respiratory tract disease. So we also did CBC and serum biochemistry. There is no significant finding except the total protein was increased at hyperproteinemia due to hyperglobulinemia, and it could be due to previous infection or inflammation. And also the A to D ratio was low, which is about 0.3. So the anesthetic protocol of this case, it's ASA class 2, pre-medicated with tramadol 3 mg per kg, administered subcutaneously, and induction was done with propofol 5 mg per kg intravenously, and the cat was maintained under isochlorine 1 to 2%. ADTT tube size was 4.5, and intraoperative anesthetic management was done with atropine 0.04 mg per kg, which is to increase the respiratory rate at that point.
So moving on to the surgical protocol. So we are using surgical technique of sliding bipedical flaps to repair the cleft palate. So firstly, the cat was placed on dorsal recumbency, and the gauze was used to tie at upper 2 lower incisor to maintain the open mouth positions. And the mucoperiosteal incision was made to create 2 sliding flaps, and bilateral releasing incisions along the dental arcade was done. And then the hemorrhage is controlled with cotton swab. And blind dissection was made with periosteal elevator to isolate the nasal and oral mucosal layer at the fistula margin. And the nasal mucosa layer was closed with PDS 50 round body using simple interrupted suture pattern. And this is the finishing of suturing the nasal mucosal layer. And then the oral mucosal layer was closed with PDS 50 round body using simple interrupted suture pattern. And 2 layers were performed to repair the oronasal fistula. And the picture on the right shows the cross-sectional view of the repair, which consists of 2 layers, which are oral and mucosa layer. So esophageal tube was placed. Firstly, the cat was placed on right lateral recumbency. And then the Rochester pin was inserted into esophagus and it bulges over the cervical skin. And then the incision was made over the tip using blade 20. And the tip of the tube was grasped and pulled out through the mouth and reinsert back the tube into the mouth, and the tube was secured with Chinese finger trap.
Okay, so move on to the post-op treatment. So for the problem of the flu FERD, so we for the treatment plan, we give amoxicillin clavulanic acid 0.7 ml BID per oral from day 1 to day 3 as a broad-spectrum antibiotic. And then we also give chlorpheniramine 4 mg half tab BID per oral from day 1 to day 4 as antihistamine. And then we also give bromhexine 8 mg half tab per oral BID from day 1 to day 4 as a mucolytic agent. So for post-op cleft palate repair, we give tramadol 3 mg per kg, 50 mg per ml, 0.25 ml subcutaneously 3 times a day from day 0 to day 1 as analgesia. And then we change the tramadol into the tablet form, which is 3 mg per kg, 50 mg, quarter tab BID from day 1 to day 3 analgesia. And then we also placed the e-tube for e-tube feeding by giving 10 ml and ACL mixed with wet whiskers from day 1 to day 14 to assist feeding after cleft palate repair. And we also wear the e-collar for the cat from day 1 to day 14 to prevent the cat from scratching the tube. So for the post-op management, it is important to keep away any chewing or hard food from the cat. And we also need to wear the e-collar to prevent pawing or scratching at the mouth. And then we need to give antibiotics to prevent any infections to the surgical site. And also we need to give feeding by e-tube with soft food for about 2 to 4 weeks. And it is also important to monitor the surgical site daily and also follow up the evaluation. As for the prognosis, in this case, the prognosis is fair. This is because the rate of the success surgery for the first time is high and it will decrease upon the next surgery. And since this is the third surgery, so that is possibility, there is about 80% possibility for the cat to have the surgery fail. So for the client education, it is important for to have a proper esophageal tube care by maintaining the cleanliness and also monitor the suture site at the and also we need to ensure that the e-tube is cleared after every feeding by flushing with the water every time after we give the feed. And also we need to wear the e-collar to the cat to prevent the cat from breaking the esophageal tube. And also we need to put chew toys, so keepers, cat. And also we need to make sure that the windows was kept closed to end window. And then we also need to remove any furnitures that will allow the cat to gain access to an open window. And we need to prevent access for the cats to the balcony area unsupervised. So that's all from us. Thank you.
Okay, doctor. We will move on to the next case.
Sorry, doctor, we are having technical problem. Wait for a while, yeah.
Can you hear me? Alright. So I will continue with the second case. Okay, good morning and Assalamualaikum to doctors and fellow DVM. We are from rotation group 17. We would like to present a case on management of severe hypoxaemia due to VQ mismatch leading to cardiopulmonary arrest as a result of suspected lung pathology. Next. VQ is made of ratio between alveolar ventilation to perfusion. Next. So meet Nana, a 3-year-old spay female domestic short hair, cat weight 3.6 kilogram. She was managed indoor with up-to-date vaccination and deworming status. And next. So to begin with the history, on 27 September 2021, Nana came to UVH due to recurrent ear polyp at the left horizontal ear canal and bilateral otitis media. She revisited on the 5th October 2021 for a CT scan and laryngotomy. And she was scheduled to have surgery yesterday and was admitted to UVH 2 days ago. Upon physical examination, the TPR was within normal range, and she was bright, alert, responsive with pale pink mucous membrane and CRT less than 2 seconds. The skin tone was normal, which is less than 2 seconds. She also had a clear lung sound. However, she had a serosanguinous discharge from the left ear. Moving on to the blood result, there is no significant finding in the hemogram. However, in the serum biochemistry, there is slightly hypoglycemia and also hyperproteinemia due to hyperglobulinemia. And the pre-op management from this case is that the problem is otitis media, so we treat with augmentin, which is amoxicillin and also clavulanate at 17 milligram per kilogram of doses and concentration of 5 mg per ml. And we given it orally twice a day for 2 days as a broad spectrum antibiotic.
So the surgical procedure that planned to perform in Nana is the left ear ventral bullae osteotomy. And this was the anesthetic protocol. She was classified under ASA class 1. She was pre-medicated with tramadol 3 mg per kg, subcut 0.3 ml and Phenyramine 0.5 mg per kg IV 0.2 ml and induced with propofol 5 mg per kg IV, and she was maintained with isoflurane of 2%. And upon physical examination in the OT room, the temperature, pressure, and also the temperature, the TPR was within the normal range, and the mucous membrane was pink, CRT less than 2 seconds, skin tan less than 2 seconds, and the blood glucose level is 7.4 millimole per liter, and the lung sound was again clear at this time. And induction was done at 12:02 p.m. and the bandage was removed. She was induced with propofol IV and flushed with normal saline and intubated at 12:07 p.m. and EDTT size 3.5 was used to intubate, and lidocaine was given on the pharynx, and valve gauze were tied and terramycin ointment was placed, and the lung sound was clear. Heart rate was 160 bpm and respiratory rate was 32 bpm. And skin preparation was performed. Patient was placed on right lateral recumbency. The left ear was surgically prepared with heavy scrub, alcohol, and also followed by iodine. And at this point of time, the SpO2 is 98%, heart rate is 163 bpm, respiratory rate is 36 bpm, mucous membrane is pink color, and the average is 1 to 8, 64 with mean pressure of 80. And the ear was flushed with a normal saline. Also, at this point of time, all the parameters was within the normal range, and we proceeded with IV fluid 1 drop per 5 seconds. And once the skin preparation was completed, she was transferred to OT room at 12:37 p.m. So this was the trend of SpO2. So we can see there was a fluctuation in the SpO2 level. So what we did was we tried to change the position in the right lateral recumbency, from the right lateral recumbency to the dorsal recumbency. We pump oxygen via ampubac, and also we used 3 other blood pressure machines to evaluate the SpO2, and all the machines showed similar findings. Also, we checked the EDTT placement and compared with other EDTT sizes externally. And once the SpO2 reached 44%, we had a second thought on going on into the surgery. Also, moving on to the next slide, concurrently we found out that the mucous membrane color reducing from pink color to bluish mucous membrane, and also the lung sound at the left side was clear. However, at the right side, there was no sound heard. So we decided to abort the surgery. And we recovered the patient in the OT room, and before that we take a radiograph beforehand, and we monitor the temperature. It was 32.4 degrees Celsius at that time, and we provided with warm blanket support and also hot water bag, and also we continue to monitor the fluctuating SpO2, so we supplied oxygen, and at that point of time the SpO2 was within the range around 96 to 100%, and we also placed nasal prong. So the respiratory rate, the heart rate, and also the blood pressure was within the normal range. And once we already stabilized the patient, we removed the EDTT tube.
So Nana was transferred to ICU at 1:47 p.m. So for the first problem, which is hypothermia, so we provide warm blanket support and check temperature every 15 minutes. So this is the graph of the temperatures starting from 2 p.m. up to 3:15 p.m. So for SpO2 problem, we provide oxygen and monitor SpO2 percentage via BP machine. And this is the SpO2 percentage trend starting from 2 p.m. up to 3:30 p.m. And we can see that the SpO2 percentage start to drop drastically. So we give bromhexine 1 mg per kg, 1.7 ml IV, aminophylline 6 mg per kg, 0.9 ml IV, and hydrocortisone 2 mg per kg, 0.15 ml IV. And for the heart rate was ausculted every 50 minutes, and the heart rate was monitored in the BP machine. So start from 2 p.m. to 3:15 p.m. we started to see the heart rate start to drop. So this early 0.04 mg per kg IV was given. And then during stabilization in ICU at 4:45 p.m., we start to notice signs of cerebral edema, in which the left eye of Nana was bulging, and mannitol, which is osmofundin 20%, 1 gram per kg, slow IV was given, for in which 1 ml per minute. And then after 15 minutes of giving mannitol, we can see that the left eye of Nana start to reduce compared to the first one. And this is the radiograph that been taken in the OT before recovery. So we can see from the VD view, the right sides of the lung, there is increased radio opacity in the right sides of the lung with the radiological diagnosis of unilateral pneumonia. And after 3 hours stabilization in ICU, radiograph was taken again, and we can see the right sides of the lung, there is increase in the radiolucent, and the lung seems to improve much more better compared to the previous one. And from the lateral view in the OT before recovery, we can see there is presence of the alveolar pattern. And after 3 hours stabilization in ICU, the alveolar pattern seems to decrease. So the treatment plan for Nana is first for hypoposition, aminophylline 6 mg per kg, 0.9 ml IV BID was given as bronchodilator. Bromhexine 1 mg per kg, 1.7 ml IV SID was given as mucolytic agent. And hydrocortisone at 2 mg per kg, 0.15 ml IV BID was given as anti-inflammatory. And for bilateral otitis media, marbofloxacin 2 mg per kg, 0.35 ml IV SID was given as antibiotic. So this is the update of Nana at 8:30 p.m. So she seems bright alert responsive. The heart rate is 180 BPM. Respiratory rate is 64 BPM. The lung sound was clear. And then the temperature is 38.8 degrees Celsius. Mucous membrane is pale. CRT is less than 2 seconds. The blood glucose is 5.5 millimole per liter. And the SpO2 was 97%. And average blood pressure is 136 per 95, and the mean pressure is 107. And also we can see from this video, the meanest response on affected eye, which is the left eye, is positive but slight sluggish compared to the right eye, and the palpebral and corneal reflex is positive. So that is all from us. Thank you. Is there any question?
Hi, can you hear me? Hi, good morning. I'd like to, in your introduction, you talk about alveolar ventilation, the VQ. So, could you explain what happened in this case in terms of this VQ?
So doctor, VQ stands for ventilation and perfusion ratio. So it is a common complication of the general anesthesia. And in this case, we related with a VQ mismatch is because the animal was keep on breathing by itself. However, the SpO2 is keep on fluctuating, indicating that the perfusion was not good. So yeah, doctor.
Could you, so the animal has been breathing on its own, the perfusion is not good. What perfusion are you pointing to?
Oxygen perfusion, doctor.
Sorry, again?
Oxygen perfusion, doctor.
Okay,
Gases exchange, doctor.
all right. Okay, and I saw that chlorpheniramine was given in your pre-medication. What's the indication of giving that?
Clofeniramine was given actually because the animal is actually having allergic to the augmentin. However, before before surgery in the pre-op management, augmentin was given, so we worried that the animal might show reacts to the augmentin, so that's why we give clofeniramine, doctor.
All right, and finally, the video that you showed. Can you please move to that slide? All right, how do you check Manet's reflex? Palpebral and corneal reflex. Is the video relevant?
Doctor, usually like we will be like closing one eye and then we will like if we are hitting towards the one eye, I mean the eye which is open. So if the cat is like moving away, so it's like it means that it having a positive Manet's reflex.
What about the following two?
For the palpebral, and for the palpebral, we touch the medial canthus or and the lateral canthus of the eyes. And for the corneal reflex, we touch the cornea, so the eye will retract back into the socket. So that's how we see the corneal reflex.
Yeah. So if you put a video like that and you say that the Manet's, the palpebral and corneal reflex is positive or negative, it's not relevant. You have DVM3 and even DVM4 here that might have, maybe they have not learned about eye. So this will give them a wrong information. So please be careful on that.
All right, doctor. Sorry, doctor. The videos and also the PE was done separately, and we put it here because we want to show that the cat is much better compared to the previous one. It's our mistake, doctor. Sorry.
All right, thank you.
Hi, can you hear me?
Yeah,
Can you hear me, students?
Yes, doctor.
I can hear.
Okay, so from your readings, right? So what is the common causes of VQ mismatch?
So, doctor, from our reading, the causes of VQ mismatch are usually atelectasis, patient positioning, and accidental endobronchial intubation, bronchospasm, pneumonia, acute respiratory distress syndrome, any airway obstruction, hypoventilation, and as well as pulmonary arterial hypotension.
our case, it is more to pneumonia and also the atelectasis.
Soon you have one more question in the chat box. Someone want to know about EDT size. Purpose of comparing EDT size externally.
Oh, it's because we used EDTT size 3.5 and then we want to confirm that the placement of the tube was accurate or just at the thoracic inlet area, because we want to make sure that the gas is supplying to both of the lung lobe and not only at one side. So that was the reason why.
Do you know what's the next plan for this cat?
Plan is to first we want to stabilize the patient first in the ICU, and once the patient is already stabilized, we plan to send the cat to home, because whenever the perfusion rate is not that good, we can't proceed with the surgery, because later on in future this problem will reoccur. So we have to stabilize the patient first, doctor.
Yeah, what's the long-term plan? Do we plan to perform the surgery again? Try to put the cat under anesthesia and go in for surgery, or we are not going to do anything, maybe just a short GA to remove the polyp via traction instead of VBO.
So for a long-term plan, we need to do several diagnostic workup, and we need to
Find out the underlying problem, the lung pathology, and we have to manage it and treat it medically. Then once if everything is clear, then only we can consider the surgery. So first we have to know the underlying lung pathology and treat it well.
All right, good. I think for CE, if you provide this answer, maybe it's okay, but to be better, maybe you would like to mention what kind of diagnostic that you want to do, and what is your highest suspicion at this point of time, and how to tackle it. All right, thank you.
Thank you, Doctor.
Okay, just to add some some points for relevant to this case. The ventilation perfusion, sorry, is an alveolar ventilation to perfusion ratio actually, and this mismatch is common complication of general anesthesia. What happens is that the air left within the lungs at the end expiration, which is called the functional residual capacity, is reduced with general anesthesia, and it reduces particularly with a patient in a dorsal recumbency, and this decreases functional residual capacity, leading to VQ mismatch or reduced alveolar ventilation. And in this case, we saw that during the preoperative skin preparation after the induction, SpO2 was good, and that was almost 30 to 35 minutes time period after the induction. And when we transfer the animal to OT, and when we put the animal in the dorsal recumbency, and immediately after that, the SpO2 went down. So after analyzing all the things and trying to reinflate gradually with the reservoir bag with the IPPV, we were unable to get the SpO2 to the normal levels. And then after lung auscultation, we went to the radiograph at this point, which is the point where the student missed. And then in the radiograph, we find out the lung collapse, and also seek the radiologist's opinion. And after that, we turn back to the OT and try to inflate the alveoli. There is a point when we try to inflate with the reservoir bag gradually, the SpO2 went up again. But when we left it, the IPPV support with the reservoir bag, the SpO2 went down again. So that's how we decided to abort the surgery. Thank you very much.
Thank you for the sharing, Dr. Ubed. No more question. Can we move on to the next case, doctors?
Yeah, please move if there's no more question.
Thank you, Doctor.
Good morning. Can everyone see my slides? All right. All right. Good morning, everyone. We are from Rotation Group 1, and today we are going to talk about approach to heat stroke in a dog. So for patient signalment, Hogan is a 3-year-old male Rottweiler weighing 44.2 kg, and the vaccination status for this dog is not stated. So for the history, on the 27th of October 2021 at 12:50 p.m., the owner put a muzzle on the dog and placed the dog in a van with no air conditioning to be brought to UVH as a blood donor. At 1:20 p.m. upon arrival, the owner noted that the dog collapsed and was panting vigorously. And at 1:30 p.m., the dog was immediately sent to the ICU ward. Upon physical examination, the temperature was 42 degrees Celsius and the pulse and respiration was not taken. The dog was panting vigorously. It had tachy and congested mucous membrane, and it was also salivating and frothing from the mouth. The dog also had muscle tremors. So, how we identified heat stroke was based on symptoms that include vigorous panting, temperature of above 40 degrees, central nervous dysfunction, drooling, salivating, and frothing at the mouth, heart rate elevation, vomiting or diarrhea that can be bloody, lethargy and muscle tremors, anuria, seizures, as well as coma. Predisposing factors for heat stroke may include high environmental temperature, highly humid environment, excessive physical activity, inadequate water, obesity, upper airway obstructions, prolonged seizures, as well as predispositions such as Labradors, retrievers, and brachycephalic dogs.
So we'll be briefly explaining about what happens during a heat stroke. So in this case, Hogan was brought in a van with no air conditioning. So when exposed to factors such as no access to water and being confined in a small space with no ventilation and a very high humidity environment such as our country, Malaysia, there is a reduced ability to dissipate the heat. And in addition to that, Hogan was also muzzled because he tends to be aggressive towards strangers. So this significantly reduces Hogan's ability to pant and remove heat from the body. So then Hogan starts entering a phase of heat stress. So in heat stress, what happens is the peripheral vasodilation occurs as the body tries to redirect the heat away from the main organs by means of convection. So in this case, the cardiac output is then reduced, and as hyperthermia progresses, eventually splanchnic pooling of the blood occurs, which is the circulation near the gastrointestinal tract, and this actually reduces the overall circulating blood volume. So what happens next is
Hogan will undergo hypovolemia, which then leads to hypotension. As temperatures elevate again and the compensative measures fail, the body temperature rapidly starts to increase because the hot blood is not able to be moved away from the central body, and this is how it leads to heat stroke. So once the temperature of the dog has reached 41.5 to 42 degrees Celsius, the heat causes direct cell toxicity and necrosis to any surrounding organs as well as the circulation. And this is why, next slide please, heat stroke affects many of the systems in the body. So next. The first system, which is the central nervous system, what happens when there is hypovolemia and hypotension, as well as the fact that there is direct cytotoxicity due to the increased heat in the body. So the cerebral perfusion is reduced, as well as leading to cerebral edema, and this will all contribute to neuronal degeneration. So the dog may be presented in altered mental state, including disorientation, stupor, seizures, muscle tremors, and coma. So in this case, Hogan was brought in with muscle tremors. Next is affecting the coagulation. So this is because the direct cytotoxicity will affect, first and foremost, the endothelial cells of the vasculature, as well as once it starts affecting the other organs and causes cell necrosis as well. And it can also affect the bone marrow. So all of this direct injury causes high release and consumption of coagulation factors and platelets. And this causes a condition known as disseminated intravascular coagulation, as well as thrombocytopenia and prolonged prothrombin time and prolonged activated prothrombin time. Due to this, we can start to see changes in the dog, such as petechial hemorrhage, which could be seen on the abdomen of Hogan at the time, as well as malachesia, melena, and hematuria. Hematochezia and hematuria. So Hogan started developing hematochezia about 1 hour after we completed cooling the dog. Next. Okay. So initially, as shown as what happens in the initial stages of heat stress, the cardiac output, the peripheral vasodilation, and central vasoconstriction is increased because the body is trying to shunt the hot blood away from the vital organs. So once this compensatory mechanism fails, the blood in the venous pool remains, and then it becomes central vasodilation. So it becomes hypovolemia and then hypotension. This may also lead to electrolyte imbalances, metabolic acidosis, as well as production of microthrombi.
So in the pulmonary system, the direct injury to the pulmonary vascular endothelial cells will lead to pulmonary edema and also increased pulmonary vascular resistance. And this will lead to the life-threatening acute respiratory distress syndrome. In the GIT, the direct cytotoxicity, prolonged hypotension, hypovolemia, and also the production of microthrombi will lead to decreased perfusion and ischemia. And the decreased perfusion will lead to cellular hypoxia, which will produce reactive oxygen and nitrogen species, and this will stimulate the inflammatory cells. And all of this will compromise the integrity of the GI tract. So once the GI tract integrity is compromised, the GI tract permeability will increase, and this will allow the translocation of bacteria and bacterial products such as endotoxins, and will lead to bacteremia, endotoxemia, or sepsis, which will cause further ischemia, cardiac dysfunction, and shock, which will eventually lead to death. So in the renal system, direct thermal injury and also protein denaturation due to the high body temperature will lead to tubular necrosis. Indirect injury can also occur, which is secondary due to decreased cardiac output, vasoconstriction, and dehydration, which will cause decreased renal perfusion, leading to hypoxia and also causing tubular necrosis. In exertional heat stroke, where the dog's muscle activity is increased, it will lead to increased skeletal muscle breakdown, which will produce myoglobin caused by rhabdomyolysis. And myoglobin is nephrotoxic, meaning that it will cause damage to the tubular structure in the kidneys, and which will lead to tubular necrosis. And tubular necrosis will lead to AKI, or acute kidney infection. Acute kidney injury, sorry.
Let's move on to the emergency treatment during the heat stroke management. We divide it into two, which is initial therapy and also external therapy. So extended therapy, sorry. For the initial therapy, first we need to take a history taking from the owner to see whether the dog having any underlying disease and what the cause of the heat stroke. And the emergency approach of ABC, which is airway, breathing, and circulation, are very important in this case. Move on to the next slide. So for the cardiovascular system, we need to see whether there's any heartbeat, and if there is, then just monitor throughout the heart rate. And also for the perfusion, we need to see from the blood pressure machine, and if it's a hypovolemia, then treat accordingly with this crystalloid fluids. And if it's a normal perfusion, we can give fluid therapy, is either short rate or maintenance rate according to the situation. For the airway, we need to ensure that the patient are having a good SpO2, which can be seen in the blood pressure machine, and continue monitoring the patient. And if it's not, then just keep a oxygen therapy. We need first either we give intubation or the face mask. For the breathing, ensure that the organ can breathe spontaneously, and if it's not, then you can incubate and use an MP bag to facilitate the breathing. For the next slide, we need to monitor the patient, which is a CRT, mucous membrane, and also mentation of the dog, which is quite early responsive, moribund, or bright and alert. Temperature is very crucial in this case, and heart rate and pulse quality. We need to establish the IV port so that we can give IV therapy, which the short rate of 20 mg per kg over 50 minutes to ensure the good blood perfusion, and gain the access to the IV so that we can give any medication, also do the blood test. Blood glucose also need to be monitored. If it's hypoglycemia, that we can give glucose in the IV fluid. Oxygen therapy, and also establish a urinary catheter so that we can monitor the urine output. In this case, for the heat stroke, it's very important to do active cooling, which is fan, and air conditioner for the ventilation. And also we can give a cool water bath, which is continuously allowing the water throughout the body so that the body can dissipate the heat, and massage the extremities. However, soaking the dots in the water bath, or also giving ice pack treatment are not recommended because of complication that we explain later.
After the initial stabilization of the patient is done, and the patient is already normothermic, the temperature is below 39.5 degrees Celsius. The next few hours and also the subsequent days, we need to address any long-term side effects or long-term adverse effects of the heat stroke, mainly in the four major systems that has mentioned in the pathophysiology, which is the gastrointestinal, renal, cardiovascular, and also neuro. Firstly is the gastrointestinal. First, we need to administer any gastroprotectant, since we know that the heat stroke causes the reduce in integrity of the cell, the gastrointestinal lining. Consider giving drugs that reduce the gastric acid to reduce the occurrence of gastric ulcers. Give an anti-emetic such as metoclopramide to reduce any nausea, and also give local protectant to protect the lining of the intestines. If you see after the first few hours, you see that it develops hematochezia, melena, or hematemesis, consider giving broad spectrum antibiotics since translocation of the normal flora of the intestine can occur, which can lead to sepsis. This antibiotic therapy should be continued until the clinical signs resolve and the patient starts to eat on his own. Next is the renal system. After we have catheterized the animal and monitor the urine output continuously, if the animal is oliguric or anuric, despite giving intravenous fluids, we should consider giving furosemide or mannitol as a diuretic. Next. For the cardiovascular system, we need to monitor three main things. Firstly, the ECG. If your clinic has an ECG machine, we need to see if there's any ventricular arrhythmias, since heat stroke can cause the damage to the heart. If there is ventricular arrhythmias, we should consider giving lidocaine bolus IV and continue with CRI. For the coagulation factors and the prothrombin and the activated prothrombin time, if there is reduced, and if you see there's particular hemorrhage or any suspecting disseminated intravascular coagulation, we can consider giving blood transfusion for this dog. We can consider giving any whole blood or frozen plasma protein, which contains the clotting factors needed. And also monitor the blood pressure. If despite the vigorous intravenous fluids, there is persistent hypotension, we can give dopamine CRI. For the neurological, the next few hours we need to monitor changes in mentations and other neuroscience such as blindness and also dilated pupils. If you suspect there is increased intracranial pressure or cerebral edema, we can give mannitol to reduce the intracranial pressure and also improve the microcirculation of the cerebral. Or if mannitol is contraindicated in cases of intercerebral hemorrhage, we can consider giving a hypertonic saline solution. But we need to first make sure that the animal is adequately hydrated. And also to give nursing care to reduce any continuous increase in intracranial pressure by elevating the head and also avoid compression of the jugular veins. Next.
So what we need to avoid during management of heat stroke? First, we need to avoid use of ice because ice will cause peripheral vessel constriction, and this will cause decrease in ability to lose heat through convective mechanism and inhibit heat dissipation from organs and muscle. Second, we need to avoid gastric lavage or cold water enemas because this will cause constriction of vascular beds of the gastrointestinal tract and lead to which cause worsen gastrointestinal ischemia and lead to bacterial translocation. Third, we also need to avoid shivering as when we need to stop the cooling method when the rectal temperature reaches 39 to 40 degrees Celsius, as further decrease of temperature will cause shivering and lead to heat production. We also need to avoid large doses of crystalloid fluids, especially in altered mentation dogs, as they are more prone to have cerebral edema.